Hi there. My name is Aliza. I am joined here by Dr. Alan Spiro, MD, and Dr. Sasha Gutfraind, PhD, for a conversation about medical ethics and artificial intelligence. Dr. Alan Spiro is a healthcare leader with over 30 years of experience in bringing innovative ideas into operational reality. Until very recently, Dr. Spiro was SVP for Strategy and Analytics and Chief Medical Officer for Blue Health Intelligence. He is co-founder of Accolade, Inc., an on-demand healthcare concierge for employers, and was a founder of AIM, now owned by Anthem. Dr. Spiro holds an MD degree from the Columbia University College of Physicians and Surgeons and an MBA degree from the Kellogg School of Management at Northwestern University. Dr. Spiro currently works with a small number of cutting-edge companies to help them with clinical, analytic, marketing, management, and operational strategies. Dr. Sasha Gutfraind is a senior healthcare data scientist with 10 years of experience in data science and healthcare. Most recently, Dr. Gutfraind was at Blue Health Intelligence, where he led the development of predictive analytics and artificial intelligence. Dr. Gutfraind holds a PhD in applied mathematics from Cornell University and serves on the faculties of Loyola University Chicago Medical Center and the University of Illinois Division of Biostatistics. Hi there, welcome.
Hello.
Nice to be here.
Can you please each introduce yourselves and describe your professional background?
In the context of this discussion, I am someone who has spent a good amount of time with both descriptive analytics and predictive analytics when it comes to healthcare, and have seen both the promise and the potential pitfalls. So I'm very happy to take part in this conversation.
Thank you, Dr. Spiro. Dr. Gutfraind?
I am a mathematician in medicine, and it's kind of a personal discovery and a personal journey for me. You know, I imagined all my life that I would be doing some math stuff, and here I am, like, discovering all this stuff about medicine, and for the last 10 years I've been basically on this journey of learning medicine and figuring out how we can use math, computer science, of course, as well, to make medicine and change medicine and improve patient care. And it's been really a phenomenal journey.
Excellent. So our conversation is going to take place in two parts. Our first half is going to be about medical ethics and the outlook for medical AI. And our second half is going to be the problems and solutions with modern AI algorithms. So what is your outlook on AI in healthcare?
I will start. I think AI holds tremendous promise in healthcare in a variety of ways. It's already being used to do readings of both pathology and radiology in a what I'll call care delivery type setting. And in that sense, it can be very exact and very specific, and perhaps even improve upon what a human radiologist and pathologist can do, never replace them, because as we in medicine know, for the most part, medicine is not about yes or no answers. It's about gradations and where something is on a continuum. And that includes, by the way, an X-ray or an ultrasound or an advanced imaging scan, as well as a pathology slide. And I, for one, think that you'll always need that human element even there. In the areas that I've been spending most of my time, and that is trying to predict and even prescribe what will happen based on previous data, I see great promise for that, and believe that it will impact care. Again, part of the challenge will be making sure that it impacts care in a way that is not limit care. And by that I mean whenever you're dealing with large populations and large distributions and multiple variables, you can't be so arrogant as to think that you have every variable in every situation. And you have to have some sort of piece in place to ensure that you're actually finding those, for example, low probability, high consequence events, and not missing some at the same time that you're not subjecting people through over-identification to unnecessary tests and interventions. So it's complex, but it shows great promise.
I have very much the same feelings, but of course I don't have the clinical insight that Dr. Spiro has. You know, what I see is an incredibly interesting and very powerful technology, and I've been involved in the projects which are very ambitious, projects that are trying to say we can make a prediction, 12 months into the future as to the state of health of this person, or we can make a prediction as to whether like a heart attack would happen using millions and millions of patient records. And when we built those algorithms, we saw incredible predictive power. And so that makes me wonder. And I think that there is clearly some areas where AI, machine learning, techniques like that could be very impactful. And these are very specific little solutions that could be built out. I don't know on the bigger question as to whether AI could be like a transformative, disruptive technology. I don't know if AI and machine learning can ever be sufficiently powerful and sufficiently free of errors to really, to some extent be kind of almost like the primary care physician for a lot of patients. And I think that maybe they can, maybe they can't. That needs to be seen.
So how do you think that AI can improve the quality of medicine?
Medicine has many elements of quality. I actually like to think about the quality of medicine to include the quality of the scientific care, the quality of the service, the quality of the administration, and the quality of the caring, the human element. I think that there's multiple areas where AI can improve the quality of clinical care and even administrative care and perhaps service. When you anticipate someone's needs, you can service them more effectively, for example. So there's a tremendous amount of potential, I believe, to really impact greatly in a positive way the entire approach to quality of care. But again, it's not going to be a panacea. It's not going to be a total answer. So we've got to make sure that we use it as a tool and not as a standalone solution.
So I'm not a doctor or like a medical doctor, so everything I say about medicine should be taken with a grain of salt. So I can't really answer the question as to how AI can impact quality of care, but I can speculate. And from what I hear, there is a huge shortage of doctors, especially specialists. You can think about, rural America where you're, hundreds of miles away from a medical center or a specialist. Or you can think of rural Africa where there is like a fundamental shortage of doctors of any kind. And for those places, having an AI doctor or an AI specialist that the person can refer to could be tremendously impactful. So that's one thing. The other thing where we have to think about is the amount of data. When we are now in the kind of this omics age where there is all this, proteomics, genomics, everything, all this flood of data that's coming in, and AI technology is ideally suitable for that because it's a technology that becomes more and more powerful the more data you feed into this, and that's another way where AI could improve the quality of care.
Thank you. Some people like Eric Topol argue in deep medicine that AI will revolutionize healthcare. So if you could please tell us who Eric Topol is and what your view is on that.
I think that Eric Topol is one of the great thinkers in medicine today. He is somebody who is a cardiologist, head of the Translational Institute of Scripps Translational Institute in San Diego. and a prolific writer and commentator. He's someone who has not only written about but used in his own practice many more technological interfaces, wearables, portable ultrasounds, etc., and has advocated for their use, but also for their use as a data source. So I think he's well equipped to comment on this, and I tend to agree with his comments. He's also written, though, about, and I keep coming back to this issue of making sure that it contributes to the humanism in medicine and doesn't detract from it. And that's something that I think has got to be a major focus as we develop AI systems in healthcare. It's interesting that there's clearly a revolution going on in healthcare in so many ways. Technologically, there is; analytically, from a data integration point of view, even culturally. When all of a sudden people are getting comfortable with seeing the doctor on a screen rather than in person, for example. So it's really important to understand these dramatic changes are occurring, and machine learning, artificial intelligence are contributing to it, are part of it, but they alone are not only what's driving it.
Now, I think that I don't have much to add about that, but I definitely recommend Eric Topol's book, Deep Medicine. I think that's a really interesting read for people from a computer science background.
Yeah, I would like to comment on one other thing that, and you're saying that, and it also relates to your comment about not being a medical doctor. The walls are being broken down as to what I'll call practices medicine. There's a certain, of course, duty, and there's a certain part of caring for people that is in the realm of the medical doctor, but there's also so much more going on in medicine that involves people who have never been in medicine before, engineers, mathematicians, from the humanities side, philosophers. There's a whole issue of the narrative in medicine by people who are in the English and in the humanities in those regards. And I bring that up because one of the challenges going forward is how do we merge all that into seamless care of individual patients? And we also have to think about the fact that because I deal with a lot of people who are not coming from clinical disciplines, there's sometimes a belief that there's this mystery in medicine, and there's certain elements that you can systematize and certain elements that you can't. I think that there's ways to use systems in every element of medicine, even assessing whether someone is caring or not. But I want to stress the term using them, not letting them take over it. And none of them are complete solutions. And you have to almost get past that sense of mystery a little bit so that you can effectively create teams that include the physician, the nurse, the mathematician, the philosopher, the sociologist, in order to make the best solutions.
Yeah, and I agree, and I think that this is a point that is a very important one. When we talk about ethics, and I think we're planning to talk about ethics shortly. When you have traditionally you had the physicians, the nurses, make the Hippocratic oath. They make actually uphold and train to uphold certain ethical standards. Well, if you're broadening the cycle of caregivers, then it really applies to everybody now. I mean, now a computer scientist working on medicine has a certain duty to patients. A data analyst, building a data set of health benchmarks, now has a duty of care to patients. It's a very, it's a state where we're not really prepared, I think, to the ethical consequences.
Absolutely. I agree.
So what are some of the core ethical principles that must be built into the AI system?
Well, for me, there's, and years ago, I actually gave a lecture on population ethics versus individual ethics. And they are different. You can make an argument on population ethics basis that, by the way, as Zeke Emanuel did in an article he wrote in, I think it was the New Yorker, a year or two ago, he made the argument that, people should just be willing to die at age 75. I'm nearing that age. I'm not willing to die. But he's right from a population ethics point of view, from a quality of life here and from a pure quantitative standard. Shouldn't we taking money that we invest in 75-year-olds' health for dialysis, for cardiac surgery, for whatever, and apply it to better maternity care, to better pediatric care? So there's a limited resource argument that says on a population basis this is ethical, and perhaps it's not ethical to do the opposite. From an individual patient point of view, what's most ethical is what's in the patient's best interest. And that's, by the way, the classic way that physicians have been taught. When you bring in mathematicians and data scientists who are taught that a single individual point in a trend is something that should be thrown out because if it doesn't fit the whole trend, you're dealing in a whole different level of ethical discussions. It brings up different ethical issues. So in my mind, a lot of these ethical issues are how do you reconcile individual versus population ethics, number one, and how do you build systems that account for those low probability, high consequence events and build them in so that you're not discounting the people who are suffering in those ways.
Especially since a lot of the AI systems are sponsored by insurance companies.
They are sponsored by insurance companies. They're sponsored by big hospital systems, which are also trying to be efficient and be able to produce their margin under shrinking budgets. Even internationally, when I go to meet with my international colleagues, which they do pretty often, they complain about shrinking government budgets when they're government funded. It's a challenge, and the way they deal with it is through these kinds of systems approaches to medicine. There's also the old saying, if I could put it that way, the old belief, and I think we've all suffered from it, that in our computer age, when a problem occurs, it seems to be impossible to challenge it, move it. Once you get complex computer systems, you can get into the arrogance of the computer system, if I could put it that way, and developers. The Boeing 737 MAX is a perfect example of that. And in healthcare, that can certainly be catastrophic. And so there has to be a way ethically to monitor and watch for that.
I'm curious, Alan, about your perspective on this another element, which is kind of the privacy element. And so some of the biggest disasters of recent times were data breaches, and now everything is computerized with EMRs everywhere. It's kind of we're in a situation where whenever a doctor enters anything into an electronic medical record, the data could be anywhere tomorrow. How does as a doctor, how do you feel about kind of the privacy of your patients?
Yeah, and that's a huge issue. I mean, I happen to come from the belief set that the patient should own their own data, and that it should be clearly their data. Now, I know that, but I'm also the optimist saying that people are willing to share their data for bigger analytic purposes. And because people are basically social animals, and if the argument is made, they'll allow that. because I do think that's an important component as well. But I don't believe in coercion to get there. I don't believe in it being a standard. I do believe in people owning their own data. Having said that, it's nothing that will be solved easily. The best medicine is collaborative medicine. So you need ways to share data between professionals. As much as I say people should own their own data from an ethical point of view, I worry if there's somebody who is, for example, has a real problem with substance abuse, but chooses to hide the fact that they're a substance abuser and is trying to get different, the same medication from different doctors for different conditions in order to accumulate something that will harm themselves, that's a problem. So you've got to be creative in your thinking. I'm not going to sit here and say that I have an answer, because I don't. But that's why they have to be discussed, and that's why these ethical issues have to be written about, talked about, and not just accepted as inevitable. You've got to find solutions.
Yeah, it's very interesting hearing your perspective. I'll tell you one other thing is, in my academic life, we have, when we do data collection, academically, especially on patients, there is this complex IRB process where, you have to make sure that data collection, doesn't do harm. You're not doing any kind of, nasty medical experiments on patients. But beyond that, there is this notion of consent. You cannot collect data from patients without consent. And yet, I feel like sometimes when we are doing AI systems, we are kind of doing that a little bit. We are basically we are not really asking for very direct permissions from patients whether to build an AI system using their records. We kind of are building an AI system using their records, which is a little troubling.
Yes, and I agree with that 100%. And it's funny that you mentioned the IRB system, because one of the, I think, best books ever written, which was before the era, because about 30 years ago, of AI, about other professionals. And what he was talking about was more sociologists and philosophers, et cetera, getting into the healthcare system, was a book by Rothman entitled Strangers at the Bedside. And in it, he talked about the fact that we're getting all these different perspectives in medicine when it comes to investigational studies and our IRB committees. And we're now, and that may very well be a good starting point, if I can put it that way, for how we structure solutions around ethics in the world of machine learning, artificial intelligence.
Are there any other ethical questions that you faced in designing healthcare systems?
Oh, there are so many. There's issues of equity. There's the rapidly becoming classic example of the system that predicted certain patients, but since they're doing it on the basis of claims data, they over-predicted African-American patients because African-American patients access care less. And that created a bias, what I'll call a mathematical bias in doing that. So there's questions of equity in there. There's, if you go back to Avitas Donabedian, who is considered the father of healthcare clinical quality, and very interesting man who grew up in Lebanon, Armenian in Lebanon, and went through a lot of personal difficulties. And he talked about 7 pillars of quality in healthcare, which include efficacy, efficiency, optimality, acceptability, legitimacy, equity, and cost. And he considered all of these these quality issues. I would make the argument that they all also become ethical issues as well. Because if you optimize a system for cost, for example, you may not be there's an ethical problem in doing that if it doesn't also optimize efficacy. So what I'm getting at is it's always a balancing act, and the balance for all these different pieces is very, very difficult.
It's a very interesting reference. I can say like I spend a lot of time talking to people who are in the population health business, epidemiology, and I would say that this entire strand of scholarship comes under this big umbrella of disparities. Yeah. So disparities. I mean, it's basically like from what I can gather, it's really a central question of healthcare systems because we have different populations and there are pervasive disparities between different populations, and it's a question that medicine tries to address, and of course AI coming into this has to deal with as well. How do we deal with the fact that there's different life expectancies in different populations? How do we deal with the fact that populations have differences, between say native English speakers and non-native English speakers? There's differences between people who can use apps, who can use technology very readily, and others who cannot and who struggle with this technology. So, if you're putting a system that's going to be making people use technology, we are basically disadvantaging certain people. That's troubling.
So is it possible to build medical AI ethically, or is there inherent tension?
I think it's always possible to try. And I think that's the key. I actually think that the effort, rather than say that perfection is needed, you'll never get perfection, you have to have systems that continuously try to address the ethical problems, but you also need an oversight of those and an attitude of always trying to improve them.
Yeah, and there's this kind of echoes an idea that I read about in the medical ethics literature, which says it's okay to do clinical trials, but there has to be always a human supervising the machine, the trial, the science, and this is something that you cannot dispense with. That's another idea that's very important.
Yes.
So that concludes the first half of our discussion on medical ethics and the outlook for medical AI. Please join us for the problems and solutions with modern AI algorithms in part 2. Thank you, Dr. Spiro and Dr. Gutfraind.
Thank you.